right, in this lesson, we're going to talk about burn injuries. Now, this is one of my favorite things to talk about because I was blessed to have the opportunity to work in the burn ICU at Parkland Hospital in Dallas, which is where a huge amount of burn treatment research has been done over the last few decades. So the truth is, if you don't work at a burn center, you may not see as much of this, but I want to give you the most important things that you need to know to be successful in nursing school, on the NCLEX, and when you start working as a new nurse. So I'm sure you're already generally familiar with what a burn is. It's damaged skin due to some source of heat or chemical activity. Now, there's actually 4 types of burns. One is a thermal burn, which is the most common. This is caused by fire or touching something hot. This is the kind of burn that you think of. Now, radiation burn is caused, obviously, by radiation. Think of UV radiation as a common one. So even a sunburn is actually technically considered a radiation burn. We can also get chemical burns from any kind of caustic chemicals. Anything that's too acidic or even too alkaline can cause a burn. And then you can also get an electrical burn from an electrical shock. And these are pretty devastating burns because they kind of travel throughout the body. Now, the biggest problem with any kind of burn is that we're losing the benefits of the skin. What are our benefits of the skin? Well, the top benefit is that it helps to protect and prevent infection. It's literally our barrier between our body and the outside. The other thing it does is it helps us regulate temperature. So think about if we're hot, we start sweating. And then it also helps us to regulate our fluid volume. I mean, it literally physically holds the fluids into us. So patients are at risk for infection. They're at risk for hypothermia. They're at risk for hypovolemia. Okay, now the big reason they're at risk for hypovolemia is this capillary leak. It's exactly what it sounds like. The capillaries start leaking fluid. So that fluid can leak out of the vessels into third spaces like the abdomen or the extremities, or it could actually leak out of the wound itself and then it's just gone altogether. So again, hypovolemia is a big risk for these patients. Now, you're probably relatively familiar with the degrees of burns as well, but let's review them really quickly. A first-degree burn is red and painful skin that is intact. So a great example of this is a sunburn. Or anytime you get a thermal burn and it's just you don't contact it for very long, you can get a first-degree burn. Now, a second-degree burn is a partial thickness that involves the lower layers. It's gone all the way through the epidermis and it's started to affect the dermis. So you're either going to see broken skin or blisters. So this area right here is a second-degree burn. Then these areas down here that are red and intact would be first-degree areas of burn. Now, third-degree burns extend all the way through the dermis. You know, you've got your epidermis, and then you've got your dermis, and then you've got your subcutaneous tissue. Remember, in your dermis, this is where your nerves are. This is where your blood vessels are. And so if I burn all the way through those layers, I'm actually going to burn through the nerves. So a lot of times these third-degree burn areas are actually painless, which is weird because they're actually pretty severe. You may see white or black eschar. It's like leathery and thick. So this area here, this whitish light pink area, that's your third-degree burn. So what we're seeing is essentially dead tissue. My husband actually sustained a third-degree burn by stepping on a coal that he had dropped out of the grill. As soon as I saw it, it was white, it was leathery. I was like, well, that's a third-degree burn. So keep that in mind. Those patients are going to need extensive intervention. And then fourth degree, there actually is a fourth degree. This is when muscle or bone is involved, and it's really common in electrical burns like you see here. Like I said, electrical burns can be very, very devastating. So we want to be aware that this is the extent that they can cause damage deeper than just the skin. So let's say you're working in the ER and a patient comes in with a burn injury. What do we need to do? Well, first thing is we need to make sure that the burning has stopped, especially if we're dealing with a chemical burn of some sort. We want to remove the chemicals, we want to irrigate the wound, remove their clothes, make sure that the burning has stopped. Then we want to assess the patient to determine the severity of the situation. So the first thing we need to know is how much of their body has been burned. We call that the total body surface area, or TBSA. So for adults, we use something called the rule of nines. Now in pediatrics, you'll use the Lund-Browder chart, so you can check that out. But in adults, we need to use the rule of nines because we're more proportional. So in the adults, the head and neck are 9 total, front and back, the whole head. Each arm is 9 total, front and back. Now each leg is 9 front and 9 back. So the total leg is 18. The trunk, this is the way I remember it. I don't remember 36 because it's harder for me. I like 9s. That's why it's the rule of 9s. So the top half of the trunk is 9. The bottom half of the trunk is 9. The top half of the back is 9. Bottom half of the back is 9. So that's a total of 36 for the whole trunk. And then you have your last 1% for the genitalia and the perineum. So let's say you have a patient come in and their entire right arm is burned and the whole top half of their trunk is burned. So you've got 9 here for a total of 18% total body surface area, okay? The next thing you want to do is find out the patient's weight in kilograms. Estimated is okay, but try to get an actual weight if you can. And then, of course, we'll look at the degree of burn. We want to know how severe it is and what we're really looking at. Once we have all this information, we can decide whether or not the patient needs to be transferred to a specialty burn unit. Not every facility is actually equipped to take care of burns. So in your outline, we've provided some specific criteria just for your knowledge, just to know what might need to be transferred and what might not. And then we also want to look at any other injuries. So a lot of times burns are so dramatic that we forget to look for other injuries, and they've actually had a trauma and we miss a fracture, we miss a head injury. So make sure you're thinking about, do they have any other injuries in addition to the burn, especially if they had a fall or they were in a car accident. Those are things we need to make sure we consider. So then we're going to use this information to guide our treatment. So like I said before, these patients are at risk for hypovolemia because of the loss of fluids. So fluid resuscitation becomes one of our top priorities. And we actually use what's known as the Parkland burn formula to guide us in our initial fluid resuscitation. So the burn formula is 4 times the total body surface area burned times the patient's weight in kilograms. That's going to give you a total number of milliliters. And then that you want to do half of it over 8 hours and the other half over 16 hours. So you're going to get this total volume in over a 24-hour period. Okay. Now, it used to be that we did it no matter what. And what we found is that some patients require less, some patients require more. So now we use this as an initial guide to our fluid resuscitation. We use this as where to start, and then we titrate it to urine output. What we want to see is somewhere between 30 and 50 milliliters an hour of urine, or about half a mil per kilo. Now, normally we would be like, oh, they had 150 mils an hour. That's great. That's wonderful. Their kidneys are doing great. Except what that means is we're over resuscitating them. So we do kind of want to keep it right in this range. So 100 kilo man, we would want 50, 60 kilos, we'd want 30, and anywhere in between. The reason we want to make sure we're not over resuscitating is we can cause a lot of third spacing and a lot of edema, and that can cause problems with wound healing. So then the second priority is infection. So remember that they have lost their skin. Not only have they lost their skin protection, but they're also now having open wounds, right? They're going to get dressing changes multiple times a day because the last thing we want is for a dirty dressing to sit on that wound. So sometimes we could do them every 6 hours, every 8 hours. It just depends on the severity of the wounds and the unit that you work on. So this is super important. We do meticulous wound care. We're using antimicrobial ointments. We're using antibacterial creams. It's really, really important that we're very meticulous and sterile with all of our dressing changes. In fact, most burn units use reverse isolation. So everyone who goes in the room is hat, mask, gown, including visitors, because we need to protect this patient from infection. And then, of course, we know they're going to be in a lot of pain. We can use a PCA if possible, if the patient's able. But either way, we want to make sure that we're medicating the patient before dressing changes because they're really painful. And then finally, we want to optimize nutrition. We know protein's important for healing, so we want to make sure they are getting enough. If we have to, we can put in an NG tube, or we could possibly even put in a PICC line for TPN. It just depends on the patient, but we need to make sure they're getting nutrition. Now, some patients, if they have severe enough wounds, they're going to require skin grafting. Most of the time, we're looking at autologous skin grafts, which is where they take healthy skin on the patient themselves, and they mesh it through a mesher, and they stretch it really big and cover up this wound. So remember, you're also now going to have a donor site. So the place where they took the healthy skin, like the leg or the back, is also now going to be an open wound. So just keep that in mind. what's cool about this is that a very small strip of skin can actually be stretched and meshed to cover quite a large area of burn. So that's really, I personally think skin grafting and skin meshing is one of the coolest things that we do as medical professionals. I actually linked a video in your outline for you to go check out and see how this skin gets meshed and stretched. It's actually really cool. So once a patient does get a skin graft, we obviously want to continue to prevent infection, and we want to monitor for rejection of the graft. I've actually seen a patient where like half the graft grew in granulation tissue and it was growing and healing beautifully, and the other half was just flapping and peeling off. So we had to cut that half off and regraft that side of it. So those are the two priorities once you have a skin graft. As we've already talked about, our top priority nursing concepts for a patient with a severe burn injury are going to be fluid and electrolytes, infection control, and comfort. Now, I know what you're thinking. What about tissue skin integrity, right? Because of the risk for infection, because of the risk for hypovolemia and the severe pain, these become priorities, but all of your skin interventions are going to end up rolled into this. You're going to make sure that you are doing really good meticulous wound care. You're going to make sure that you're addressing their pain and positioning for comfort, addressing their fluid and electrolytes, and even nutrition is all going to tie into that skin healing. So this is why we chose these as priorities. So let's recap quickly. There are 4 general types of burns: thermal, radiation, chemical, and electrical, and there's 4 degrees depending on the thickness and the tissue involved. In adults, we use the rule of 9s to determine our total body surface area burned, and then we use that percentage and the patient's weight to determine how much fluid they're going to need in their first 24 hours. But again, we use that Parkland burn formula as a guide, and we titrate to urine output, usually about 0.5 ml per kilo. Second priority is always infection prevention, frequent dressing changes, sterile environment, IV antibiotics, and then of course monitoring a graft and donor site. Remember, you have 2 wounds now when you have a skin donor site. And then pain management. We'll give them a PCA if they're able to use it, and we make sure we medicate them before dressing changes because they are extremely painful. All right, guys, those are the most important things you need to know for burns. Check out all of the resources attached to this lesson to learn more, and let us know if you have any questions. Now go out and be your best selves today, guys. And as always, happy nursing.